Let's join Dr. Janelyn Busty for a discussion on fever and infectious diseases in children.
All right, we're going to finish with sick kids, so we will still no money. We're going to talk about managing fever and evaluation of fever in children. We'll talk about some bacterial and viral illnesses, particularly of the respiratory tree, and then we'll talk about some common xanthoms of children. So what is fever? Fever is an abnormal condition of the body, an undue rise in temperature, quickening of the pulse. Fever is defined as greater than 100.4 or 38 degrees Celsius. The rectal temperature is the most accurate. It doesn't indicate serious illness, so the higher the temperature doesn't necessarily mean that they're more seriously ill. It mostly will cause them to be uncomfortable, can cause seizures, doesn't cause brain damage, and it does help to fight infection. So parents often come in and say, his temperature was 102. If he's in daycare and he's 2 years old, you're going to see that all the time. So here is your 14-day-old infant who's brought to your office for a weight check. The rectal temperature is 100.8. The infant appears well and the parents have zero concerns. What should you do? Should you A, reassure the parents and just schedule a follow-up in 24 hours? Should you give acetaminophen, observe, and send home if the fever resolves? C, should you do an outpatient sepsis workup and follow up in 24 hours? Or D, should you admit and do an inpatient sepsis workup? All right, and most of you know that the correct answer is to admit and do an inpatient sepsis workup. So let's talk about fever in the first 30 days of life. If you have a rectal temperature greater than 100.4, do not pass go, do not collect $100, send them straight to the hospital. If you do not admit, talk to whoever is going to do your admissions for you, but this child needs to be admitted. You will do a standard set of blood tests and other tests on these children. You'll do a CBC with a differential, you'll do blood cultures, you'll get a chest x-ray, you'll do a urinalysis with a urine culture, you will do a lumbar puncture under the age of 30 days. If they have diarrhea, you can consider stool studies. So the causes in the first 30 days of life for any kind of bacterial infections, it's group B strep, listeria, and E. coli. And if you think about kids being born, those are the bugs they're most likely to be exposed to. The treatment in the first 30 days is AMP and GENT, or you can do ampicillin and cefotaxime, plus or minus acyclovir. If you remember my previous talk when I talked about herpes, if you have any suspicion of herpes, maybe even if you don't have a suspicion of herpes, you want to think about acyclovir. You don't use ceftriaxone in the first month. It's just a little extra. So what if you have a child who's now over 30 days of age, but less than 3 months, who looks toxic? So what does it mean if they're toxic? Well, they're cyanotic, maybe they're limp, maybe they're irritable, they're not feeding well, they have poor tone. You just treat those kids exactly like you would those kids under 1 month of age. You admit them to the hospital and you do a full septic workup. So what if you have a child who actually looks pretty good? They come in with a fever. Mom and dad say, I didn't know he had a fever. He's been doing great. I had no concerns. You can actually manage these patients as an outpatient. So you still want to get a CBC. The guidelines always say CSF. I don't know if you'd be doing an LP in the outpatient, but if you did, you would want your CSF to have less than 8 white blood cells, your WBCs to be less than 15,000 with less than 1,500 bands. You'd want to get a blood culture. You'd want to get a urine culture. You need to do a urine cath on that. And you'd want to give them 50 milligrams per kilogram of IM ceftriaxone, and then you need to see them back the next day to go over those results and see how the child is doing. Now, the other thing that you have to consider is the child needs to meet certain low-risk criteria. So it needs to be a full-term infant who's had no medical problems. So a child who stayed in the NICU or had a prolonged course of antibiotics at birth would not meet this. You need to have reliable caretakers. So you have to have parents who understand what a sick child looks like. They have to have transportation. They have to have a phone. And it has to be a phone that doesn't cut off 5 minutes after they leave your office. They need to have a willingness to return in 24 hours. In my population, this pretty much rules everybody out. If you're in a population that this does not rule them out, this is an appropriate board answer for this situation. Febrile seizures, fairly common, 3 to 4% of all children, most commonly in that toddler period, between 9 months, 20 months. 30 to 40% will have a recurrence. So if you have a child with a febrile seizure, you got to warn parents there's a good chance it'll happen again. Again, family history. If it happened in mom and dad, there's a chance it'll happen in the child. It's more likely to happen in the child. It is not associated with brain damage. And here is a good board question. No further workup is needed for a febrile seizure besides trying to find out what caused the fever. So all you do is you say, look, he had an ear infection. We'll treat the ear infection. You do not need to do a head CT. They do not need an EEG. They do not need a pediatric neurologist. This is a hard conversation to have with the family, but the fact is there is no indication to do any further workup. All right, so you have a 3-year-old girl who comes with a 4-day history of fever without any other symptoms. On exam, her ears, throat, lungs, abdomen, everything seems completely normal, but she still looks really lethargic to you. What should be your next step? Would it be A, just treat the fever and reevaluate her in 24 hours? B, order a urinalysis with cultures? C, get an abdominal ultrasound? Or D, administer some IV fluids? This is a 3-year-old girl. Great, the answer is B, order a urinalysis and cultures, and that is because urinary tract infections are the most common serious bacterial infection in children when there isn't an obvious source. So when you look and their ears look fine, their lungs sound fine, and they just are febrile and look sick, most common bacterial cause is urinary tract infections. Most of it's E. coli, no surprise there. In newborns, it's premature and uncircumcised males. By the ages of 1 to 5, it's mostly girls. And this anatomically makes sense. This is when they're potty training. They haven't quite learned the whole white front to back thing yet. You do need to get a urine culture, and you cannot do a bag urine. And I know those of you who work in emergency departments and urgent cares, maybe the nurses say, please, can't we put on a bag? No, it has to be a catheterized urine. If the child is toilet trained, so 2 to 3, 4 years of age, you can send the mom in to get a clean catch. It's always fun. How do you treat a urinary tract infection? You have to have a positive culture of greater than 50,000 colony-forming units. Cephalosporins are the first choice, so this is cephalexin. You can use things like Bactrim or Septra. There's a lot of times questions about when to do an ultrasound. And so the correct answer is if the first febrile UTI is less than age 2, because you're concerned possibly that there is a congenital malformation leading to the urinary tract infection, or if they have a recurrent UTI. What's recurrent? 2 or more. So if they have 1, and it's a girl, our 3-year-old with the urinary tract infection, doesn't need any further imaging. If she has 2, she needs an ultrasound. Voiding cystourethrogram has to be done also with recurrent febrile urinary tract infection. So again, if she has 2, that's when you would consider that. Or if on your ultrasound you notice that there's some abnormalities. All right, you have a 16-year-old female with a 4-day history of a sore throat, non-productive cough, and rhinorrhea. She is afebrile. Exam reveals enlarged tonsils, erythematous tonsils, but no exudate, no lymphadenopathy. So what is the next step? A, supportive care. B, a rapid strep test. C, treat with oral penicillin for 10 days. Or D, treat with azithromycin for 5 days. Please do not answer this based on what your most recent Press Ganey scores were. Remember, this is the boards. All right, you all know the right answer is A. And that is because most pharyngitis is viral. So I told you earlier that breastfeeding is always good, smoking is always bad. In kids, most infections are viruses. And that's an important concept to remember. We're family physicians, not ear, nose, and throat doctors or pulmonologists. So group A strep is 15% of the time cause of pharyngitis. So these are your center criteria. You probably learned these as medical students and have quickly forgotten them. But if you have moderate to severe tonsillar swelling with exudate, moderate to severe anterior cervical lymphadenopathy, absence of moderate or severe cough, and a fever, those 4 points together, if you have all 4 of those, you don't even test, you just treat. If you have none of those or one of those, you don't test or treat. You tell them it's a virus, just do supportive care. If you have 2 or 3 of those, this is the time where you want to do your rapid strep test and then treat if positive. The treatment, of course, is penicillin, classic board question, which prevents rheumatic fever, but not that post-strep glomerulonephritis. And the suppurative complications are abscesses, peritonsillar abscesses, retropharyngeal abscesses. These are, of course, the people who come in with severe throat pain. They can't swallow, they're high fever, they can't eat or drink. They often are leaning forward, they got that muffled voice, can't open their jaw, very, very high white count. And the treatment for an abscess, always, no matter where it is in the body, is drain it. So in this case, you'd also give them some IV antibiotics, but the answer is you have to drain the abscess, as it is pretty much everywhere in the body. Epiglottitis, I haven't seen a case of this since residency, mostly because of the Haemophilus influenza vaccine, which was the primary cause of this. So if you got a question that said an unvaccinated child comes in, remember the board never gives you any information unless it's really pertinent to the answer. You'll see that cherry red epiglottis. You can kind of see it looks like a little thumb, big swollen epiglottis there in that x-ray. The key thing with this is airway management, because of course they can occlude their airways, and so you want to make sure whoever's your airway management specialist is nearby, whether that's you or someone else. You treat them with cephalosporins, clindamycin. You don't use steroids. You don't use racemic epinephrine. Viral URI is the bane of all of our existence, because everybody wants it fixed, and there's nothing to fix them with. Over-the-counter cold and cough medicines are not recommended under the age of 5. We've known for years that they don't help. We now know that under the age of 5, they're actually dangerous. So there are no cough and cold medicines for this age group. However, there's actually some decent evidence for honey. And so I tell not under the age of 1 because of the concerns about botulism, but over the age of 1, you can give them honey. Do not use antibiotics despite your Press Ganey scores maybe taking a dive. A 2-year-old child is brought to the emergency department with a barking cough, stridor, that worsened tonight, and a temperature of 101. What is the treatment? A, nebulized albuterol. B, inhaled steroids. C, nebulized epinephrine and dexamethasone. Or D, humidified oxygen. Great, so the answer is C, nebulized epinephrine and dexamethasone, and that is because this is croup. So what is croup? Again, it's a virus. It causes edema of the upper airway, so that causes that sound, that stridor sound, and then also that barky cough, mostly caused by parainfluenza, can be adenovirus, RSV, can be mycoplasma. The symptoms are pretty classic. You can hear a croup cough down the hallway. If you're in the next room and you come out and you hear that cough, you don't even have to do more than walk in and say, let me treat you with your dexamethasone. If you did do an x-ray, you would see the narrowing of the airway. The other thing to remember about croup is if you see them in your office and you don't hear them cough, when are they going to get worse? 10 o'clock that night when they show up in the emergency department. So just be aware to try to hear that. If you hear that cough, do something about it. The treatment of this, though, is dexamethasone. And this is a change from those of you who may be trained in the past. And any severity of croup gets dexamethasone. The dose is 0.6 milligrams per kilogram. You can give it IM. You can give it oral. You can keep it in your office and give it to them right there. It's just one dose. It shortens hospitalization rates and shortens ED stays. And you give it for any severity of croup. So even if the kid looks great and you just hear that croupy cough, go ahead and give it to them. If they do come to the emergency department, or if you're in an urgent care center or an office where you have nebulized epinephrine, that'll give immediate relief. However, if you give them epinephrine and dexamethasone at that point, you probably have bought them at least an overnight stay in your hospital for observation. Do not use albuterol or other beta-agonist bronchodilators. All right, the other bane of our existence. 9-month-old child admitted in January for a cough, wheezing, decreased feeding, and a fever of 38 degrees Celsius. Chest x-ray shows mild parabronchial cuffing. Which treatment is indicated? A, amoxicillin clavulanate. B, systemic corticosteroids. C, supplemental oxygen and fluids. Or D, nebulized ipratropium. All right, the correct answer is C, supplemental oxygen and fluids. And the reason for that, of course, this is bronchiolitis, most commonly caused by respiratory syncytial virus. This is the most common cause of bronchiolitis and pneumonia in kids under the age of 1. So these are the kids, they look like they have a cold, but they are wheezing. They have wheezing and rhonchi. They may not really look all that sick. They're kind of that happy wheezer, but you can often walk into the room and hear them wheezing. You can diagnose it with the antigen detection assays. The treatment is supportive. It's oxygen if they need it. You can check their oxygen saturations, and if they need oxygen, give it to them. Tylenol fluids. You can use nebulized saline to kind of help loosen up some of the mucus in their airways. There is no bronchodilators used. This is a change. These guidelines came out about a year ago. They used to say try albuterol, erase that from your brains. You now want to just do supportive care. No evidence for steroids, antibiotics, or anything else for that matter. Oh, pertussis. As David mentioned earlier, we're seeing a recurrence of pertussis. If you haven't ever seen that whooping cough, it's pretty remarkable. It's that cough, 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 and then they cough, 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 cough. There's great videos on YouTube if you want to see it. They often will cough to the point of vomiting. And for children, it's important to remember it can cause seizures and it can cause apnea, so especially in small infants. If they get pertussis, which is why you give a Tdap to every pregnant woman, because you don't want them to become apneic. Pertussis and bronchiolitis may present with apnea. No specific physical findings, except you'll just hear that big whooping cough, and they can also have pneumonia. The treatment, if they're under 3 months, you're going to admit them. It's supportive care. You do treat them with erythromycin. You can do clarithromycin, azithromycin, mostly to halt the spread. Doesn't necessarily fix the pertussis, it halts the spreads. You do need to treat all household contacts. And of course, we talked about the Tdap as a single booster dose. Of course, you give it to your moms to make sure that that child is protected in those first couple months. Just something to keep in mind. In our emergency department, they often say, sounds like pertussis and treat them. If you're going to treat someone for pertussis, child or adult, you need to test them because that is a reportable disease. So if you think it's pertussis, even if you're not sure, test them, because if it comes back, and you can go ahead and treat them, but if it comes back positive, of course, you have to go on to treating all the household contacts and notify your local health department. Pneumonia, most common causes? Viruses. Again, viruses. However, for bacterial causes, it's important to know that there's a difference between preschool kids and school-age kids. Remember, in ages 0 to 1 month, it's that E. coli, group B strep, listeria, bacteria. After that, you start thinking about strep pneumo, Haemophilus influenza, so you treat with amoxicillin. So kids, 2 months to 5, amoxicillin. Once they get into school, you start thinking about Mycoplasma pneumonia, so you treat with azithromycin. So if you have 2 siblings, a 9-year-old and a 3-year-old, mom may say, why are you treating them with different things? Well, because they have different potential bugs. Gastroenteritis, most common cause? Viruses. Again, viruses. Rotavirus and norovirus. David's going to talk a little bit more about this later. Bacterial causes, E. coli 0157. This is one that can lead to hemolytic uremic syndrome in about 10% of the time. Bloody stools, think Salmonella, Shigella, Campylobacter, or C. difficile. In a child of the signs of dehydration, they may not breathe well. They may breathe slowly or quickly. Decreased skin turgor. They can have sunken fontanelles. Prolonged cap refill. One of the best ways to see if a kid is really sick is just pinch their cute little fat toes and see how their capillary refill is. You don't need to do stool studies unless they've had it for more than 14 days, or if there's bloody diarrhea. I know in our hospital this is a quality measure, and so we get little nasty grams if we order stool studies in less than 14 days. Your main treatment is oral rehydration. So you make sure that they stay hydrated and let it pass. Don't give them antidiarrheals. Could consider probiotics and make sure that they are eating a normal diet. Methicillin-resistant Staph aureus, or MRSA, consider it in all kids. Really, for the most part, any of us who see abscesses always think MRSA unless we have a better reason to think something else. You culture it, treat by sensitivity. You can use your Bactrim, clindamycin. We usually don't use tetracyclines, but so the first 2 are your go-to choices. All right, you have a 2-year-old boy with very red cheeks and a fine rash, but he doesn't look sick at all. He had a fever a couple of days ago. When can he return to daycare? Is it A, today, B, tomorrow, C, in 5 days, or D, after the rash is gone? And the answer is today. And that this is Fist disease. So everyone knows that, wow, I know what this is. But the problem is you have to know what the course is of it. You can see it's caused by parvovirus. The rash is actually immune-mediated, so it occurs after the infection. So they get the infection is going away, and they get this big rash. Pregnant women can get complications, fetal hydrops, fetal demise. You often will hear daycare workers coming and saying, oh, we've got, Fist disease in our daycare, and they can be concerned about fetal complications. Measles is making a comeback. I know for a while there, I hadn't seen measles probably in 15 years, starting to get little bits of it coming back. The prodrome of fever, malaise, anorexia, and the classic C's, the conjunctivitis, coryza, cough, and Koplik spots are your diagnostic criteria. Has that rash beginning on the face, goes down to the neck, trunk, and extremities. And the reason why we worry about measles and we vaccinate our children is because they can get things like pneumonia, encephalitis, and all kinds of other terrible consequences. Roseola, again, a very common rash that shows up in children, very mild, sporadic. They get it in the preschool years. Usually they start out being sick again, high fever. They get better, rash comes out. If you can see this is a picture of it. It's those pink sort of macular-papular rash, mostly on the trunk. Pretty much all kids have it by age 3. HSP, because my German is really no good at all, it follows a URI with low-grade fever, fatigue, and so the classic triad, and again, on the boards, they're going to give you the classic presentation. This will be a child who had a URI and now has purpura, colicky, abdominal pain, and arthritis. So the rash is, again, maculopapular rash, our favorite, progresses to palpable purpura on the buttocks and the legs, so it's the lower half of the body. You get hematuria, proteinuria, increased sed rate, white count, increased platelets, and if you have renal complications, you can treat with prednisone. So there's our palpable purpura on the lower extremities. So this is one of my favorite. We have oddly been seeing this over the Christmas break and since then. Lesions on the hand and feet, usually in the late summer and early fall. This, of course, is hand, foot, and mouth disease, which we see all the time. Usually in kids less than 5. I've been seeing it in teenagers. Not sure why that is over the past couple months. Late summer, early fall, oral fecal spread. Incubation period's about 4 to 6 days. Again, they have the fever, sore throat, anorexia, and then the rash comes out. It comes out on the hands, the feet, can come out on the butt. So it could be hand, foot, and mouth and butt disease. And it usually just goes away. The biggest risk with this is the mouth lesions in particular can be very, very painful. So children will sometimes refuse to eat, and so you may need to use whatever your favorite magic mouthwash is or some kind of topical agent for those lesions. So another rash on the hands typically begins, again, 3 to 5 days illness. First appears on the hands, feet, ankles. And this one has another classic triad, which you probably won't see that often, but you'll get it on a board question, which is fever, rash, and tick exposure. Only happens in real life 20% of the time. It happens 100% of the time on board questions. So what is this? It says Rocky Mountain spotted fever, one of the few things that shows up with rashes on hands and feet. It's the most common fatal tick-borne disease in the U.S. It's the American dog tick. Sudden onset of fever, muscle pain, nausea, vomiting, rash, abdominal joint pain. These people look very, very sick, unlike your kids with hand, foot, and mouth disease, who generally are looking pretty good because the fever has gone away. The lesions begin as macula and papules, which become petechial and hemorrhagic, start on the palms, soles, goes to the legs, not on the face. What do you treat them with? Doxycycline. Oh my gosh, what if you're worried about their teeth? You treat them with doxycycline. Oh my gosh, are they going to have yellow teeth? Yes, you treat them with doxycycline. So the answer is doxycycline, unless they would like them to be dead. So most parents would prefer the yellow teeth to dead. A 5-year-old male has 7 days of spiking high fevers and a diffuse erythematous rash. Tongues and lips are dry, red, cracked. He has very large cervical lymph nodes. In addition to rehydration, what is your next treatment steps? A, outpatient steroids and high-dose aspirin. B, outpatient antibiotics and high-dose aspirin. C, inpatient IV antibiotics and high-dose aspirin. Or D, inpatient immune globulin and high-dose aspirin. Very good. The answer is inpatient immune globulin and high-dose aspirin because this is Kawasaki disease. So this is a diffuse vasculitis. It's the leading cause of acquired cardiac disease in the United States. And so the diagnostic criteria are important. It's more than 5 days of fever, the bilateral conjunctivitis, the oropharyngeal erythema, the strawberry tongue, the induration of the hands and feet, so you start getting the desquamation on the hands and feet, the erythematous rash all over the body, and the big lymph nodes, greater than 1.5 centimeters. They have to have 4 of the 5 of those. So the risk of this is coronary artery aneurysms. So we give the single dose of IV immune globulin. You give high-dose aspirin. You do an echo at onset in 6 to 8 weeks. And if they do end up with one of these giant artery aneurysms, they have to be on aspirin and warfarin. Meningitis, just like pneumonia, there are different causes at different age groups. So 0 to 1, we're back to our friends Group B strep, E. coli, and listeria. You can throw a little Klebsiella in there just for fun. The empiric treatment is exactly what we talked about before, ampicillin and gentamicin, or ampicillin and cefotaxime, plus or minus acyclovir. 1 to 3 months, we're starting to add the preschool age bugs in there. So you can think about ceftriaxone or cefotaxime, plus or minus ampicillin. 3 to 5 months, strep pneumo, Neisseria, ceftriaxone, and cefotaxime, maybe vancomycin. 5 to 18, strep pneumo and Neisseria. And again, this is now, you're really getting more to what you would think about when you do your adults, ceftriaxone or cefotaxime plus vancomycin. Neisseria meningitis is that gram-negative Diplococcus. These are the abrupt fever. These people are sick if you've ever seen this. They come in and you can watch them from the time they go from your office to they get to the hospital to start developing this rash, becoming more and more sick. They, of course, can develop purpura, DIC, shock, and then they can die if not treated quickly. So the other thing I wanted to mention is we talked about the meningitis B. It's actually more common in infants, the meningitis B, but the vaccine is for older children. There's many reasons for that. Our CDC person is here. Perhaps they can give us a little insight on that. The treatment for this, again, is ceftriaxone for meningococcal meningitis, cefotaxime. There's no evidence of vancomycin is increasing survival, and you can use dexamethasone. There's some pluses and minuses with that. It really was used more in other types of pneumonia as opposed to meningococcal. So the last thing I want to talk about just for a moment is frequent flyers on the boards. Community-acquired pneumonias, the ones I talked about, the preschool kids get amoxicillin, school-age kids get azithromycin. Croup, know croup and know that dexamethasone is the treatment for any kind of croup. Bronchiolitis, know that you don't really do anything except supportive care. Pharyngitis, strep versus viral. Kawasaki's, I have no idea why Kawasaki's shows up on the boards, but it shows up almost every single year. Pertussis, what not to do mostly for viral URIs. Urinary tract infections, again, more of the follow-up treatment for that. Sepsis workup for newborns. Remember the temperature of 100.4. Admit them if they are 0 to 1 month of age. And the other thing I would just throw in there is maybe take a few minutes and just review the initial steps of NRP or PALS. There was a couple questions over the past few years of, what would you do if a newborn came out and didn't have a heartbeat? So take a few minutes and just review the first few steps of that. And there are your answers if you missed them. Thank you very much.